Rhett Nelson with OSPI. I facilitate these monthly webinar series with GATE. This ongoing monthly series began in response to our first statewide district survey focusing on systems and practices to reduce dropouts and increase graduation rates. One of the requests from districts in the survey was guidance on who is being successful and how are they doing, what are they doing. This webinar series tries to highlight some of these success stories around individual topics that have shown to increase student success and decrease dropouts. One of the challenges districts have repeatedly highlighted and emphasized has been the need and absence of mental health supports. A lot of what's going on out there and what districts are asking for, the more we learn, the more we're seeing that maybe we don't know how to actually start getting some of those systems in place. So today we're going to hear from Sara Ellsworth with ESD113, who has been working with the AWARE project on putting some mental health supports into a school and providing mental health supports to schools in the region. A little more about our goals here today is I like to frame everything with OSPI's vision and mission. Our goal at OSPI is that every student is ready for career, college, and life. And to do that at our state level is to provide funding, resources, tools, data, technical assistance to enable educators such as yourself to ensure that students are successful in our public schools. So this enabling mission is how can we better help and serve you, the districts out there that are serving the students. We have a series of performance indicators that we're using to measure our success. My particular area happens to be 4- and 5-year graduation rates, attendance, especially chronic absence, as well as 9th grade failure rates. This of course, is much broader. This subject today is much broader than those, and we'd hope to see success amongst all these performance indicators if we're better meeting the mental health needs of these students. Just a little plug for the webinar series. We have this our series archived online at the GATE website listed here. Our upcoming webinar is next month, May 6th, and it will be on dual credit. It's a Friday. It's different than the rest of our series. You can see that we've got a series of interesting topics: attendance, several on attendance, some data use. So hopefully you'll be able to come and check those out if you're interested, if you find this valuable. Without further ado, I would like to pass it over to Sara. Let me change the presenter here. Sara, are you out there?
Yes, can you hear me?
I can. There we go. And you
can see my screen, I trust, because I can't see my screen.
Oh.
I mean, I can see my screen, I just can't see it on the webinar. So everyone out there can see my screen?
Yes, we can see your
screen. Okay, perfect. Thank you. Thank you for that introduction. Again, I'm Sara Ellsworth. I'm with the Capital Region ESD113. For those of you who don't know, ESD113 is one of 9 educational support districts across the state. We serve a 5-county region that includes Thurston, Mason, Grays Harbor, Lewis, and Pacific counties. I've been working at our ESD since 2008 in our student assistance program. Prior to that, I have experience working in public mental health and juvenile justice. I'm currently our behavioral health clinical services manager and provide clinical supervision and support to staff on our True North Student Assistance and Treatment Services program. Staff at True North provide comprehensive behavioral health services that include both mental health and substance use prevention, intervention, and treatment. Today, we'll be speaking specifically about our mental health and co-occurring services. So these are our objectives for today. What I want you to walk away with is a foundation for why mental health services are needed in schools. We'll discuss the development and implementation of one of our school-based co-occurring projects in Thurston County, review some of the lessons learned from that project, and essential elements that we found to be most important in building a school-based mental health program. So hopefully by the end of the webinar, we'll have accomplished all these goals. So let's start with why mental health in schools. We have found three main reasons that this has become a necessity. And I say necessity because anybody who knows me knows that this is my particular passion, and my belief is that school-based mental health services should be an essential right for all students in Washington State. So let's talk about why I feel that way. First of all, students in Washington State are experiencing significant mental health issues. Those issues are happening and they're becoming more and more severe. Students with mental health and substance use or co-occurring issues are less likely to graduate from high school. And despite our best efforts, students are not connecting with many of the services available in the community due to a number of barriers. So when we look at why mental health in schools, this is our Washington State Healthy Youth Survey data. This data was taken specifically for the overall Washington State population. For those of you who aren't familiar with Healthy Youth Survey, what it is a survey of students in Washington State that is conducted every 2 years. Participation is voluntary and schools have the option not to participate. Healthy Youth Survey is an effort to measure health risk behaviors that contribute to morbidity, mortality, and social problems among youth in Washington State. These results are from our 2014 administration, which was the 14th such statewide survey, and participation in 2014 included over 220,000 students from all 39 counties. So this is the representation of that total. For those of you who are connected to a school district or a school building, I would encourage you to look at this data for your own district or building to see how it does compare to the state. But what we see when we look at this is students are experiencing significant mental health issues, and we also see increased suicidal feelings and actions. These definitions, when you look at depressive feelings, feeling anxious, or can't control worrying, the questions asked on the Healthy Youth Survey are students who report feeling sad or hopeless for at least 2 weeks in the past year. Feeling anxious are students who report feeling nervous, anxious, or over the edge for the past 2 weeks. And can't stop worrying are students who report not being able to stop or control their worrying. When we look at this data, it's highly alarming. We see over half our students in all 3 grade levels, 8th, 10th, and 12th, where these questions are asked, report feeling anxious during the past 2 weeks. And a significant amount of those students are reporting that they can't control their worrying. We also see over a third of our students in 10th or 12th grade report that they felt depressed for 2 weeks in the last year. When we look at suicidal feelings and actions, the numbers are lower, but they're still alarming. When we look at our 10th grade rates, we see that 1 in 5 students in 10th grade have considered suicide as an option, and over 15% of those have made a plan. The numbers for attempts are lower, but they're still concerning when we see 1 in 10 of our students in 10th grade have made a suicide attempt. Again, when we look at data, these numbers become even more concerning for our students who are using substances. I found this data by conducting a question-by-question analysis of the Healthy Youth Survey data, comparing recent substance use and mental health symptoms. When we look at students who are using alcohol, we see far higher and more significant rates of depression, anxiety, and suicide. As well as students who are using marijuana, we see far higher rates of depression, anxiety, and suicide than their peers who have not used substances. Again, when we talk about current substance use, that means that these students reported using either alcohol or marijuana at least once in the past 30 days. When we talk about depression, those are those students who reported feeling depressed for at least 2 weeks in the past year. Anxiety are those students who in the last 2 weeks felt that they were anxious, nervous, or on edge. And for suicide, we talked about, or this was looking at those students who had contemplated suicide. So now let's talk about mental health as it relates to graduation. The second reason that we want mental health services in schools is that we know that students with mental health and substance use issues are less likely to graduate either on time or at all. This report that was published by the Department of Social and Health Services looked at the complex relationship between behavioral health risk factors associated with health and service needs and high school progress and outcomes for DSHS clients who began 9th grade in 2005-2006 academic year. What they found is youth with behavioral health needs were less likely to graduate from and more likely to drop out of high school than youth without behavioral health needs. And those youth with co-occurring needs were the least likely to graduate on time. Only 12% of students in this particular study with co-occurring needs graduated on time, and they were the most likely to drop out at 80%. The report also reviews graduation rates by categories. For students with no known behavioral health need, 63% of those students graduated from high school, 56% on time, and 7% late. Students with just mental health needs, only, well, less than half graduated, 36% on time and 10% late. Those with substance use only a fourth of those students graduated. And for students who had co-occurring needs or both mental health and substance use, only 17% of those students graduated. This is very concerning. And the third reason we talked about needing mental health in schools is despite our best efforts, students are not making it to services in the community. There are a number of reasons for that. Sometimes those services are unavailable in the community, or sometimes for various reasons they're essentially inaccessible to students. The 2015 Parity or Disparity Report completed by Mental Health America shows that Washington State ranks among those states with the highest prevalence of youth mental illness and the lowest rate of access to care at 47th overall. We're at the very bottom in terms of our youth being able to access the care that they need. We're also 43rd in the nation for children who need but do not get mental health services. 42nd in the nation for students identified with serious emotional disturbances on their IEP. And of the students in Washington State, 64.8% of youth are privately insured, 31.4% receive public benefits, and 3.8% remain uninsured. Those particular statistics, I think, are important when we look at our service model and how services have historically been delivered in a school-based program. Oftentimes what that looks like is an outside provider, generally a Medicaid-funded outside provider who comes into a school district to provide services to students. What that means is some students then have access to services, but again, many of them do not. When we look across our state, only about 30% of our students would be Medicaid funded, and so in any given school that means still 2/3 of your students may not be able to access the traditional school-based mental health services as they've been delivered in the past. Other considerations in terms of access to care and reasons that we've seen that students frequently don't make it to the services in the community is a lack of resources in rural areas. Oftentimes, what we see for our rural students, and our region in a whole is very rural, is that the closest service provider is over 30 miles away. So that requires the student and the family to travel oftentimes over 60 miles round trip to get to their community-based mental health appointment. That leads into transportation issues. Frequently, that sort of a trip is just not possible for many of our families and many of our students. Or there's no bus service that's available to get them to and from those appointments, or their parents aren't able to take off work to be able to get them to and from those appointments. So those become major issues. Another issue that we run into is, by law, our students have the right to access care on their own over the age of 13. That means if I'm a 15-year-old student, I have the right to receive mental health services without the consent of my parents and without my parents knowing. If I am an insurance patient, meaning I'm on my parents' insurance and I'd like to seek services on my own, that's functionally impossible. What will happen is my parents will receive a billing statement of the services that I receive, and it will be clear that I've been seeing a mental health therapist, and my right to have that remain private has now been violated. So that's a major issue, and one barrier that we see to students not seeking services on their own is they're not ready to address these mental health issues to their parents for whatever reason, or their parents are resistant to them getting services, and so they just are not able to do that. And we also see a disruption to academics for mental health appointments in the community. In our region, one of the common practices is that assessment appointments are not scheduled, but rather these are available on a walk-in basis between the hours of 8 a.m. and 5 p.m. What that means is that a student or family would have to arrive at the local community mental health agency sometime between those hours in the hopes that there would be a walk-in appointment available. That often requires students to miss school because the earlier you get there in the day, the more likely you are to be able to get a walk-in assessment appointment. And it also means that on that day, if it's particularly busy, you may not get to see someone that day, and after waiting several hours, you may have to come back another day. That's very concerning for our students who, as we know, have mental health needs, are frequently not doing well academically, and that amount of time out of school is challenging. Another common practice in our region is that once an assessment is completed and a youth is determined to meet access to care standards, meaning that they qualify for the mental health services that they need in the community, our local mental health provider is unable or unwilling to offer after-school appointments until a pattern has been established of regular attendance. So this means a student may be assessed, find that they need services, and the only appointment time they're offered is during the school day until they can show 6 weeks of regular attendance, meaning that for 6 weeks the student must be taken out of school to be transported to and from and during the time that they participate in their mental health services. And we talked about our rural areas and how far that can be for some students, and that's close to half a day or a full day out of school to attend their mental health appointment, which is not conducive to academic success and oftentimes is unrealistic for parents who have jobs and are unable to transport their students. So for all these reasons, what we're seeing is a very solid foundation for why we need mental health services in schools, to make them accessible to our students, to help our students focus on their academics and increase graduation rates, and to address those needs that are there and frequently unmet. So what I'd like to talk about now, in particular, is our Rochester co-occurring pilot. This is one, yes.
I just wanted to interrupt real quick. This is amazing stuff, and I think that our listeners are also just taking all of this in. Not seeing any questions yet, but I wanted to remind our listeners that using the little question box in the chat box, you can ask questions, and we will periodically interrupt and address those questions.
And this would be a great time. How about I pause for a minute for people to formulate questions if they have any, and I can speak to those before we make our transition. Thanks, Sarah. I'm still not seeing any questions. Okay. It's either because everyone's overwhelmed with all this information, perhaps they're doing other things, or the information's so clear that we just will breathe on forward. It is clear, there's just a lot of, I really like the format that you've got here of giving us some of this, laying out these facts in such a succinct way. Oh, I just suddenly got a whole lot of questions. Oh, okay. Is there funding? Some of these you might be answering later in this thing too. We have, is there funding coming down to pay for professionals in the school? Will you please explain the 42nd rank for Washington in IEPs for emotional behavioral disorders students? Yeah. EBD? So the first question, is there funding for these services to be delivered in schools? The answer is yes, but Oftentimes, like we talked about in the traditional model, those services are tied to a particular population. Our state has just recently, as of April 1st, undergone a major transformation with mental health and substance use being joined rather than separate entities. And with that, there are some options through these behavioral health organizations for creative funding. In our region, we have partnered with our BHO to be able to expand our school-based services to be able to offer more districts this type of service. Oftentimes, however, what that does require is a match from the district because the BHOs are specifically designed for Medicaid-funded use, meaning those funds can be used to serve Medicaid populations. And again, what we are really passionate about, what we want to make sure that we do is serve all students in a school rather than a select group of students. And so the way that we've been able to do that is have districts match the funding that's provided by the BHO to cover those additional students who may not be Medicaid funded. What we do is sometimes, how we've done that is looked at free and reduced lunch rates as sort of a proxy for Medicaid funding, and the BHO would cover those students that, you know, if there were 60% free and reduced rate lunch in your district, the Medicaid funding would cover that portion, and then the district may pay a 40% match for the additional students to receive those funding. I hope that makes sense. There's lots of other creative ways that this has been done, but that's what seems to be working well in our region. And in terms of 42nd in the country for IEPs, what I'm going to do is I'm actually going to pull up that report. Can you all see as I do this? So this is the parity or disparity report for the state of mental health in America. The link is available on the PowerPoint for you to access this this report. And on page 34, it explains students identified with serious emotional disturbance on their IEP, and we can see Washington State falls here at 42nd. Our rate for students, I think this is per 1,000 students, is 4.76 students per 1,000 have their serious emotional disturbance identified on their IEP. What this report is saying is that that's a low rate. We would expect that to be higher based on student needs. And so these serious emotional disturbances are not necessarily being addressed as with accommodations in the school arena. I hope that that makes sense. Are there any other questions?
There are a few. Why don't we go back onto the presentation for a little bit, and then we'll do these again.
Okay. And I encourage you all, the Healthy Youth Survey data that I showed, the DSHS report, and also the Parity Disparity report. If you have time and you're curious, those are all really great sources of information and framing of this issue. So in particular today, because this is our longest standing project, I'm going to our longest standing behavioral co-occurring or mental health project. I'm going to talk about our Rochester co-occurring pilot. And what you will see is that this pilot really emerged out of a lot of these issues that many of you are probably here on the webinar about. So this started with a conversation and a discussion between OSPI and schools asking the question about why students were dropping out or not graduating. And overwhelmingly, what school districts were citing was mental health as one of the significant contributing factors to their either not graduating or dropping out of school. So after that, a work group was developed to look at potential solutions. Among the partners of that work group were the Division of Behavioral Health and Recovery and us here at ESD113. Through these discussions, the opportunity for a pilot project emerged to be funded by the Division of Behavioral Health and Recovery and implemented by ESD113. So once this opportunity emerged, what we did was a local needs assessment and readiness to benefit to identify a district. So we looked at a number of different factors, including several of the factors. For those of you who are familiar with the Community Prevention and Wellness Initiative, several of those factors that were used to identify our highest needs communities in our region. And we identified Rochester as a district with significant need and also high readiness to benefit. So once that happened, what we started doing was relationship building within the district and developing trust. Trust was one of my key words at the beginning of this project, because what we were trying to do was something new and different, and that required a lot of trust on behalf of the district between them and ESD113 to come in, to trust us to take good care of their students, to trust us to be good stewards within the community, to trust us to be in their building and represent their district in a very positive way. And so that was one of the guiding principles that I had, is that trust was key. Trust was key with the district, and trust was going to be key with the students that we would be working with. So as we were building these relationships and developing trust, we identified a project staff, our school-based clinician, and we started training. Training for her focused on evidence-based practices, including motivational interviewing and cognitive behavioral therapy, and also orienting her to school-based services. We also were lucky enough to find a school-based clinician who was bilingual and had the capacity to become a co-occurring clinician, meaning that she would be able to provide both mental health and substance use services in school for students who had both needs. And bilingual was especially important in Rochester, where there is a high need of dual language speaking students and families. So this is our project snapshot. Essentially, the project placed a mental health clinician directly in the school district to provide services to both middle school and high school students, including students at the alternative high school. The way that this was different than other traditionally community-based providers coming into schools is that our clinician is in the district full-time. She has no other caseload responsibilities other than serving that district. Again, what we've talked about in the past is that we see providers come in and perhaps they serve a district 1 day a week, 2 days a week, with the capacity to only see specifically funded youth and for an hour at a time, meaning for 1 day a week, you probably will receive 6 hours of services, maybe 6 students that could be served in that school building. 2 days a week, maybe 12 students. And those clinicians are often carrying caseloads outside of that district, meaning that their attention and focus is not specific to that district. But we were lucky enough that our clinician is in the district full time. She's there from the beginning of school until after school hours in order to meet with students and families at times that are convenient for them. Our clinician is also able to work with all students in need, although this does vary somewhat based on funding. That's something that started with our pilot project. She was only able to provide direct treatment services to non-Medicaid funded youth and liaison services to Medicaid funded youth. We'll talk a bit more about that as we move forward. However, this will be changing, and she will now have capacity to provide services to all students regardless of funding. And our clinician is also able to provide co-occurring services. So again, in the traditional model, a provider comes in, they're generally only providing mental health specific services, and if students present with co-occurring needs, they're either referred to an outside additional provider or those needs may not be addressed. So our clinician provides screening, assessment, referral, case management, and therapeutic treatment in our school-based program. She uses evidence-based programming that includes motivational interviewing, cognitive behavioral therapy plus, which includes cognitive behavioral therapy for depression, for anxiety, for behavior, and trauma-focused cognitive behavioral therapy. And she also utilizes the adolescent community reinforcement approach, which is a co-occurring curriculum to address both substance use and mental health issues. She also works as a liaison between the school and outside behavioral health resources, and I think that this is one of the most important things that she does in a school-based program. What we found and I don't want to get ahead of myself because we'll talk about this in lessons learned, but oftentimes schools are unaware of their students that have outside behavioral health services, and they are not providing adequate support, not because they don't care, but because they're not aware in school. This is our service model for our co-occurring pilot, which was developed by our clinician and is a very succinct way for looking at how we sort of move students through our process. So when a student is first referred either by a parent, a staff, or their student themselves, what our clinician does is she gathers information from the referent in terms of what are the problems that the student might be experiencing, what are the expectations or hopes that our program might be able to provide to the student, and she also checks to see what the student's funding is, if they're Medicaid or non-Medicaid funded, because during our pilot phase that determines who or who cannot receive direct therapeutic services. So after she does those background steps, talks with the referent, gathers information, finds out their funding, she meets with the student. Because she has a lot of referrals, she always prioritizes those referrals where crisis or safety is a consideration, and sees those kids as quickly as she can. For crisis referrals, she makes sure that the first thing she does is review confidentiality with them, and then does safety and COPE planning before moving forward with any other steps, so that they have some very distinct and tangible resources that they can utilize right away. In our pilot project, students with Medicaid are only able to receive liaison services. So what that means is they would meet with our school-based clinician. She would get some more information about them, and if they were interested in receiving services, she would work with them, providing case management services to connect them with appropriate resources in the community. And in addition to that connection to resources in the community, she would continue to work as a liaison between the school and the outside provider to make sure that the school knew what was happening with that student and how to support them. So what that might look like in real life is a student with Medicaid comes in, has a number of significant issues, is interested in receiving services. Our school-based clinician would then help connect them with the most appropriate resource in the community. If that's the local community mental health agency, she would work with them to contact them, figure out how to get an assessment and set up their appointments. Once they engaged in services, she would then do some case coordination with that outside provider, finding out, what are the needs that are being addressed? Is there any sort of crisis plan, and can we have a copy of that so it's here on file at school? The school counselor administrators know what to do if the student has a crisis on campus, things like that. For students without Medicaid, it's a very similar process. Meets with the student, talks with them about their needs, gauges their interest in engaging in services. The difference being that if a student is interested in services, they have the opportunity to provide those or receive those services directly from her at school. So they would be assessed by our school-based clinician, they would be enrolled in services, and they would be seen on an outpatient basis at school or after school, depending on their need and the appropriateness of services. So this is our school-based program services provided by month. This is for the first 6 months of our program. Our program started in January of 2015. So we are now almost a year and a half into this initial pilot. What you see is starting in January, we didn't provide any services to students. That was mostly because January was consumed with bringing our clinician into the program, providing training, getting to know people at school, and there was very little time that she was actually available to see students. So starting in February, what you can see is that each month the numbers of students that we saw had increased. This orange line is the total unduplicated number of students served across the time of the program. The purple, which is a particular note, are those Medicaid youth served, and the blue, the sort of teal, is non-Medicaid youth served. One of the things we saw over the course of the project is that the non-Medicaid youth who were unable to receive direct services at school actually often presented with the highest needs and became frequent stoppers in our clinician's office because due to the many of those reasons we talked about earlier, were not making it to services in the community. And so they were in need of ongoing support, not accessing that in the community. And so we're continuing to seek out our school-based clinician just to have some connection and someone to talk to. So for the first 6 months of our program, so from January 2015 to June of 20, yes.
Can I interrupt again?
Absolutely.
Hey, Sarah. We're getting a few questions about having folks either hired through the ESD or through the districts. Can you tell us a little bit more about the benefits or challenges of hiring clinicians through the ESD model that then serve districts or school, especially given HIPAA and FERPA?
Yes. So our recommendation is whether it's through an ESD or a local community mental health agency that you're able to create a partnership with, is that these types of partnerships and this type of work seems to work best in our experience when it's not provided by the school district. There's a number of reasons for that, but primarily what we see is in terms of liability, oversight, and supervision. There's frequently not anybody within the school district that is able to provide that type of support to school-based clinicians. I've been doing this work for over 10 years now, and I still need to rely on my clinical team for consultation, for support on an ongoing basis. And without that backup and support, we're sort of putting clinicians as islands in schools with no one to turn to help them figure out how to address sometimes very difficult and delicate and frankly life-threatening situations. And that's an awful lot of liability for a school district to take on. The other benefit is when agencies are able to contract with when districts are able to contract with a partner agency, FERPA is taken out of the equation. Everything is maintained under HIPAA. They're different than the academic files. There's no overlap there. And one of the things that is really important in these school-based programs is to ensure that the confidentiality of students is protected. And so we can ensure that these are maintained as a medical record. Students over the age of 13 have the choice and the right to decide who has access to those records and who doesn't. There's no issues with FERPA because these are not academic records. There's no concerns about these records following them as they apply to college or move forward with their lives, but that they are wholly maintained separately. So those are the two main reasons. Depending on where your region is, the ESD may or may not be an option. The reason our ESD is an option is because we are an actually licensed behavioral health agency. We're licensed by the Division of Behavioral Health and Recovery to be able to provide both substance use and mental health services. Not every ESD has that capacity, but there are community mental health providers that are licensed agencies that can do that. Again, in their traditional model, I really encourage districts to think creatively, and rather than just bring in a provider 1 or 2 days a week to provide those services, really look at how can we implement or create a structure so that this person is coming in and able to kind of be a part of the school system and really work with all those students. That's one of the things that we've been able to do that I think is crucial to building a successful program. Does that, Mandy, that was you, right? Does that help answer the question?
Yes. What mental health assessments are you using?
We use the GAIN, the full GAIN, the Global Appraisal of Individual Needs, which is a complete biopsychosocial assessment that asks students about their medical history, their social history, their academic history, their mental and emotional history, their substance use history, their justice involvement history. And so it's a very comprehensive tool that looks at all those factors. It takes about 2 hours to conduct and is mostly computer-based with a clinician asking the questions and students answering. I know we also use a lot of supplemental tools depending on their particular needs. So we'll use particular anxiety or depression screenings. We also use some trauma screens depending on need, but our main assessment is the full game.
Thank you.
You're welcome. So when we talk about our Rochester co-occurring pilot and some of the early outcomes and successes that we saw is in the first 6 months of services, 39 unduplicated students were served. We built the capacity to provide co-occurring disorders on that campus. Historically, Rochester has had support for substance use treatment from our student assistance program, but this was the first time that mental health services were available to them on campus. And what we saw was discipline offenses decreased overall in the school in the first 6 months that the clinician was there. I'm a little hesitant to say that that was solely due to the services that we provided, but what we did see that I think that we can take some credit for is discipline offenses decreased for those students in school-based services. Why that is, I have a couple of speculations. One, I think, might be that the schools have started identifying that students perhaps are acting up or becoming discipline issues because of their manifestations of their mental health needs, and instead of disciplining them, maybe the first response is to introduce them to the school-based clinician. I also think that once students are known to be working with our school-based clinician, that rather than disciplining them, they're perhaps sending her there for interventions. And so I think that those are some of the reasons. These are also just a sample of some feedback from a parent, a school counselor, and a student participant of our program. This parent in particular was of a student who was a discipline referral for substance use on campus, and mom's quote was, "It was one of the best things that could have happened for what he was going through. He was able to take a negative and turn it into a positive. We were pleased with the outcome of the whole situation." This is pretty powerful considering that many families whose students end up with discipline issues because of substance use are less than thrilled to be involved with our system at the outset. And so at the end, that she considered this to be one of the best things that could have happened to him is pretty profound. The school counselor said there are 2 huge benefits to the partnership. Students and parents have direct services that are convenient and accessible. Resources are shared. This includes expertise from the mental health professional. More time can be dedicated to connecting students and parents to services, and more students are receiving services because of the partnership. And the one that I find most powerful because it's from a student participant themselves, it's important because it helps you become the best you can be as a person. I don't want to kill myself every day anymore. Now I want to be successful. I want to be happy. That's pretty profound. So there were a number of lessons that we learned from this project. The first being schools don't know what they don't know. We knew at the beginning of this project that there was going to be need and that there would be a number of students who would identify or need these school-based services, and that there were also probably a number of students who were already receiving services in the community. What we found is we wholly underestimated the prevalence of mental health needs in this particular district. Far more students presented with needs that would qualify for the school-based clinician, and also more students were receiving outside services than I think the school was aware of, which led to questions of capacity issues. We sort of opened the floodgates, and it's, I don't remember the movie, the baseball movie, "If you build it, they will come." That's sort of what we saw, is that once it was there, all these students, these teachers, these staff were presenting with needs for students and making sure that they were getting to where they needed to go. And also the school and community's ability to respond to needs. So one of the unique things about this project that really I think has resonated for me over and over is that for most positions in a school building, be it an administrator, a teacher, a counselor, there's another person in the school building who understands the role of that particular person and who can step in to fill that role when they're gone. That is not so with the school-based clinician. They're coming in with a very unique set of skills and expertise, and there's oftentimes not much understanding in the rest of the school community of what happens in the school-based clinician's office or what to do with students when that school-based clinician isn't there. This is really important because Just like everyone else, our school-based clinicians get sick and they're out of the building. They take vacations and they're not in the building. They have meetings away from the school, and oftentimes this is when students go into crisis. And so one of the capacity issues that really we're still working on is how to build the capacity, act as a coach for district staff so that they understand the role that that school-based clinician serves. They understand some of the community and support resources, and they can help respond to a student who's having a crisis. And that if that school-based clinician happens to be busy or out of the office or unavailable at the moment a student's having a crisis, there are other staff that feel prepared and competent to help with that. Again, the role of the clinician versus the role of the school. Really, I can't take credit for this, but something I heard at a conference that I attended earlier this year was in the past our school-based clinicians have sort of been fairy godmothers that have stepped into schools and were expected to handle all the social and emotional supports from classroom presentations all the way through to direct therapy services for students. And what we found more and more with the need of students, we really need our school-based clinician available to provide those direct therapeutic services and act as a coach, again, to the rest of the school who can provide those universal and early intervention supports and even do some of the crisis response. We also realize that there are limits of a school-based program. Often students with acute mental health needs or in crisis need higher levels of care that can be provided by the school-based clinician and need to be connected with those appropriate services. There's also a need for services for students in crisis who are currently maybe suicidal or a danger to themselves or a danger to others. There need to be quick and immediate services in response for those students. So this leads us to what have we determined are some of the essential elements of a school-based mental health program. First and foremost, there needs to be key champions within the district to see this cause through, who understand the importance of these services for our youth and who can make the connections for those who may be hesitant between mental health services and academic growth. I think that that connection has to be made, is that mental health supports really do support academics, and that when we bring these services into school, they are academic supports. We also find that having a multi-tiered system of support for addressing these non-academic barriers is essential, and looking at the services at all three tiers of that MTSS. There also needs to be a multidisciplinary team that meets regularly to address student needs. Generally, this includes an administrator, a school counselor, and a school-based clinician at a minimum. It may also include teachers and other support staff within the building. There have to be multiple pathways for referral. We found that students want to be able to refer themselves. They want to be able to refer their friends. Teachers need to be able to make referrals. Administrators need to be able to make referrals. And so there need to be processes and pathways for all those people to reach a school-based clinician to make appropriate referrals. We also feel that it's important, again, to have the capacity to serve all students in a building, not just particular students who have the right sort of funding. It's essential that the school-based clinician can work extended hours. When we say extended hours, we mean extended from the traditional school day. That's because we know, especially for younger students, the more family involvement, the more likely they are to be successful. Many of our parents work. Being able to do family sessions, meet with families and caregivers outside of school hours. And also a lot of the work that we do directly provides trauma care. And what we know is if we're going to ask a student to unpack their trauma, it's better if we do that at the end of the day when they don't have to go back to school and try and be present for their academics. Another essential element is making sure that your school-based clinician is aware of and connected to community-based resources. When there are issues that cannot be met by the school-based clinician, they need to be well aware of what is happening in their community and who can help address those particular needs. And another major thing that we learned is having a school-based clinician that can speak school language, so that they understand what happens in a school, the role of a school, they understand academics, and they can help, again, make those connections in the same way as the key champions. So I feel like it's worth an extra look at the multi-tiered system of support and what this looks like at each tier level for a school-based mental health program. So in Tier 1, we see universal school-wide practices. These are for all students, and all staff can be responsible for these things. So when you're creating a school-based mental health program, you want programming at the Tier 1 level that just include a welcoming, trauma-sensitive, warm environment. It might include universal prevention and mental health promotion in the classroom. It might include making sure that all staff recognize that it's important to greet their students welcomely, openly, warmly. This includes ensuring that teachers know how to make the connections to the school-based clinician and know how to talk to students about that. But really, it's the school staff who are responsible for the supports and services at Tier 1. Tier 2 include those targeted interventions for students with low acuity or transient social and emotional needs. These services can be provided by school teachers, school counselors, and administrators. What we see in Tier 3 is this is really the home of the student assistance professional or school-based clinician, and these are those direct therapeutic mental health services for students with intensive social and emotional needs. When we look at specific practices or things that can be done in a Tier 1 support system, these are school policies, practices, and approaches that promote a culture that protects all students and boosts resiliency. These are things like having a safe and caring environment within the school, a predictable structure of the school day, clear expectations, fair consequences and redirection, trauma-informed approaches, and classroom-based social-emotional learning. Tier 2, this includes screening and monitoring for at-risk students, the multidisciplinary team, classroom-based supports and interventions. An example would be the student who has anxiety issues and may experience a panic attack during their math test, making sure that there's a classroom-based support and intervention where that student can take time out to do their breathing exercises, step out of the room to manage their anxiety behaviors, and come back. This can include problem solving and conflict resolution, social skills development, group interventions, connections to family, and community connections and referrals. These are generally provided by the school counselor, administrator, and sometimes classroom teachers. Again, Tier 3 is where our school-based clinician lives. This includes assessment and individual service planning, evidence-based mental health intervention, case management, family support and training, crisis planning and response, connection to and liaison between outside behavioral health supports, and staff training and consultation. This is a quote that has resonated for me with these programs. Your present circumstances don't determine where you go. They merely determine where you start. For schools, the way things are now are not the ways they have to be, but depending on which of these elements you have in place, that might determine where you start. And now I'll open the floor again for any additional questions or comments.
Here's a question. What does low acuity for social emotional needs mean?
So that would be a student who maybe has suffered a recent loss. Maybe is having some transient anxiety issues related to a specific event. So perhaps they just broke up with a boyfriend or girlfriend or in significant distress, but it's not something that's likely to be an ongoing long-term issue. Perhaps they just got cut from the soccer team and were really hoping to do that. They just moved to a new school and are having a hard time adjusting, but otherwise have a lot of protective factors and tend to cope pretty well. Those students don't need a lot of long-term intensive therapeutic support, but might need some Tier 2 interventions.
That was such a fantastic presentation, Sarah. We really appreciate it. You know, this has just been such a challenge for districts out there, and so sort of hearing some of these steps, I think, has been very helpful as we all think about how we can better serve mental health needs in schools. switch back to
well, thank you. I'm so pleased to have been a part of this, and as I said, I'm very passionate about it. And if people do have questions that they think of later, I'm available by email or phone, and I'm happy to talk about this ad nauseum, really.
How does it work at primary grade level?
This is a question that's come up, is how does this work in the primary, the early elementary level?
We are in the process of figuring that out. We will be putting a school-based clinician very soon in an elementary school building in Shelton. You know, it doesn't look dramatically different. Again, when we think of that multi-tiered system of support, a lot of that would look the same at a primary level. What may be different is our assessment tool will be different. We probably won't use the full GAIN that talks about substance use because that's generally not very appropriate for students in the primary level. And what also we expect to differ is the family involvement and family engagement, and them being a larger part of the interventions.
Thank you, Sarah. I put our contact information up on the screen here. If you need to contact either me or Sarah, we can get some of that, get your questions answered. We'll go through these questions too and see if there was any that weren't answered that could be better addressed. We'll send that out as well. Thank you, everybody, for joining us today, and hopefully you'll be able to join us next month for our little session on dual credit resources, May 6th.